Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing a patient who came to ER with complaints of acute agitation and altered behavior.
Okay, start.
So, a 42-year-old male was brought to ER with history of 2 days incidence onset of tremors, confusion, and altered behavior, along with irrelevant talk. It was progressive over nature, so that day morning it was got really worsened, so they brought him to hospital. On our initial 10-second assessment, patient was conscious but confused and anxious. And also,
Tremors is actually a sign, no? It's not a symptom.
but it's actually something that the bystanders noted in the patient.
Okay,
So that's why they
So generalized tremors or only hand tremors?
hand tremors mainly.
Okay.
So on our initial 10-second assessment, the patient was conscious but confused and anxious. And he was also very agitated and he was not obeying to any commands. He was not willing for any cooperating for physical examination as well. So we discussed this with the bystanders, and after getting their consent, we went for a physical restraint. He was actually a lean built but well-nourished person, so but we had to take the help of our security staff to restrain him. Total 5 members were restraining him, and we put him on physical restrainers, securing both upper limb and lower limb, and he placed him on a trolley in supine position. After that, even though since we was very much moving, we couldn't get an IV access, so we gave injection lorazepam IM 4 mg was given. And after about 20 minutes also, he was actually mildly sedated, but he was still very aggressive. So we again had to repeat it 2 more, and by around 45 minutes actually he completely calmed down. Then we again with our primary survey. So we even with ABCD assessment, airway was patent. There was no features of any airway obstruction like any gurgling or pooling of secretion. Breathing part, he had a bilateral equal air entry with adequate and symmetrical chest excretions. He had a respiratory rate of 22 per minute and SpO2 at 98% in room air. Circulatory part, he had good peripheral pulses, and heart rate was 98 per minute and BP was 140 per minute, 140 by 80 millimeters of mercury. An 18 gauge IV line was secured at this point. Disability part, he was drowsy but still arousable, and GRBS check was 103 milligram per deciliter. He had bilateral equally and symmetrical pupillary reaction, about 2.5 mm. Exposure part, his temperature was normal and he was covered to prevent hypothermia. On reassessment, his
Now you have a patient who was combative, agitative, and you have given benzodiazepines, right? What are the key things you are going to monitor?
The thing is actually a patient, especially we don't.
Respiratory depression, so PCO2 buildup, benzodiazepines can cause, especially lorazepam will have a longer course of action, and since this patient is alcoholic, it will have an unpredictable course. So constant patient has to be monitored for SpO2 and PCO2 buildup, and watched out for respiratory depression.
Alcohol is a stimulant or a suppressant in CS?
Suppressant, CNS suppressant.
Early phase?
Initially
stimulant, then
Stimulant,
CNS
then
suppressant.
suppressant.
He's not a diagnosed case of CLD, but we are not sure because he's not on a regular follow-up or anyway. So in this case, actually, if it's a CLD, the lorazepam activity can actually go for a long time. So we have to continuously monitor. So after giving lorazepam and all that, the patient was connected to a cardiac monitor and continuous SpO2 monitoring. And also an ABG was taken at this point.
An alcoholic patient become altered behavior, agitated. What are the differential diagnosis you think? Most important thing is differential diagnosis.
One could be hypoglycemia.
Okay, here you are telling 103 is the sugar. Can the patient still have hypoglycemia?
Because actually in alcohol patients, actually it could be possibly relative hypoglycemia also, because actually they hypoglycemia, because they are always like nutrition deprived, because mainly they consume only alcohol. So in this case of patients, actually even a relative hypoglycemia can cause actually symptoms.
Alcohol always keep the sugar very high. That sugar cannot be stored. So whenever you reduce the alcohol content in the body, suddenly they go to an hypoglycemic like feature. It is not actual hypoglycemia, it's only a relative problem. Like diabetic patient whose blood sugar is always very high, 300, 400. You try to treat with insulin, the sugars become 100 itself, they'll have features of hypoglycemia. So that should be kept in mind. Okay, then so one is relative hypoglycemia, that is not actual hypoglycemia. You can correct in some patients.
Then any seizure or a post-ictal phase.
Post-ictal phase.
Then any head injury, because actually this
trauma to head, fall.
They may have fallen down, he may not have remembered. Then any underlying mental illness, because a long time.
And alcohol intoxication itself
Alcohol
will,
intoxication itself can produce. Then
or withdrawal symptoms
withdrawal symptoms can
have
Then
agitation.
Wernicke's
Wernicke's
encephalopathy can be
encephalopathy,
there.
Korsakoff's psychosis.
Same thing. Wernicke's or Korsakoff.
Any meningitis or encephalitis, sepsis.
Okay. Any altered behavior can be due to infections and like okay.
Any SH or any acute stroke or
Subarachnoid hemorrhage will not produce normally altered behavior. It produce more altered clinical signs than symptoms. Headache, neck stiffness, all these things. Seizures.
Okay. So in this patient actually he clinically ruled out any hypoxia, hypoglycemia actually 103 natively.
We want to give dextrose in this patient. Suppose this patient is every day taking alcohol. 103 is the blood sugar. Suppose I am telling you to give some dextrose. May not be scientific. Even then, what we see in routine practice, we can give dextrose. Most of the patients slightly improve. But how do you give dextrose?
We have to always supplement with thiamine.
Okay. If it is not an emergency, you give thiamine, then give dextrose. Okay.
Why?
Basically, actually, in alcoholic patients, they are usually nutrition deprived. They usually take normal food intake is less. So because of that, vitamin deficiency is there. Also, actually, chronic alcohol intake can disrupt the stomach mucosa, which can again affect the thiamine absorption.
So what happens if you give dextrose? What happens?
Dextrose actually, basically, thiamine is required for dextrose absorption in the
Metabolism. So thiamine will be utilized for that. So CNS will have acute deficiency of thiamine. Any other electrolyte imbalance you want to rule out in this patient? Electrolytes.
Hypokalemia.
Hypokalemia will not produce altered behavior unless he is having a chronic liver disease. Normal person, hypokalemia will not produce altered behavior. But a patient who is having liver disease can have. Okay.
Sodium.
Hyponatremia. Okay. Why the patient should develop hyponatremia?
Dilutional hyponatremia can be there if the patient has ascites and all.
He's having ascites?
Or
dehydration.
Dehydration produces
diuretics.
hypernatremia, not
diuretics.
Depletional hypernatremia. He is not taking normal diet. Any other electrolyte which is very important for CNS?
Hypomagnesemia.
Hypomagnesemia. How do hypomagnesemia develop in this type of patients? How do they develop?
Dietary.
They lose magnesium through the kidneys. Alcohol patients, diabetic patients, kidney will lose lot of magnesium through the urine. Okay, so there will be increased magnesium loss, and hypomagnesemia is one of the cause for altered behavior, especially in alcoholic patients.
Also in chronic alcoholics, there will be always a nutrition deficiency. So actually, they utilize the muscle reserves for mechanism. It can also deplete the electrolytes stored in the muscles also. So in this patient, in the initial assessment, he was confused and anxious. So we restrained him with physical as well as chemical restraints. And then we went ahead with the primary survey, in which the airway breathing circulation is maintained and all that maintained. And the reassessment again is maintained, and we took an ABG, was showing respiratory alkalosis.
Respiratory alkalosis.
pH was 7.52 with a PCO2 of 28. Bicarb was 21 and PO2 was 98. And potassium.
Lactate, sugars?
Lactate is 2 and sugars is 113.
Okay. What are the reasons for respiratory alkalosis like this?
So CLD patients, generally we see respiratory alkalosis in that.
It's okay. Then
Or
he's not CLD, he's only alcoholic. He doesn't have CLD features.
with agitated hyperventilation.
He's an agitated patient, he can have hyperventilation. And that is the most common diagnosis in this patient. Okay.
Calcium?
Calcium was 8.9.
Okay, it's normal. Corrected calcium.
Albumin
is normal, 8.9 is the corrected calcium.
Then we went with the secondary survey. Secondary survey patient is a chronic ethanol user with regular consumption for the past 15 years. He usually consumes about 250 to 300 ml per day.
Okay.
And the maximum abstinence he has gone is about 2 weeks because he can't hold much more than that. And he had a similar history of alternate behavior in the past, about 6 months back. At that time he was admitted in outside hospital. He was treated conservatively and discharged. He never had any previous history of any seizures. About 2 years back, actually, his family members took him to a de-addiction center, but he couldn't complete it successfully. Again, he went back to his behavior. That is his current history. So what happened today is actually 2 days back he was his last intake. After that actually he couldn't get any this thing alcohol. After that he started showing initially craving like symptoms followed by confusion, agitation and irrelevant talk. Then
Time of concept of symptoms and abstinence was how many hours?
About 2 days, 48 hours.
Beginning of symptoms?
Initially it was more like craving. Then about 6 hours later it's totally started showing symptoms. Initially it was more like an agitation, then followed by irrelevant talk, and finally was even showing hallucinatory behavior. It was like hearing some of the sounds and all that. So they with that history they immediately brought the patient to the hospital. He doesn't have any history of any allergies and he's not taking any medications. The only past history is he tried alcohol de-addiction 2 years back, which he couldn't complete successfully. The last meal was yesterday evening. After that he didn't take any food. And his symptoms worsened by today morning, and which brought him to the hospital. Clinical examination, he was a lean built but nourished male.
Alcoholic patient, last meal has got any importance?
Yes, sir. Because if at all they throw a seizure or anything, risk of aspiration will be high.
And
If it's a full stomach.
Every patient is having that problem. What is the problem in alcoholic patient?
Vomiting.
They will not be taking meals.
That is not the answer.
Yes.
Diabetic patients, alcoholic patient, what is the problem in stomach? Emptying time is more. So even if like we cannot predict like a normal person it may empty by 6 hours. So you are free to intubate or whatever procedure without any fear. So alcoholic patients, that emptying time is more than a normal person. So you should anticipate again an aspiration during your procedure. Okay, so you should be very careful in this type of thing. And emptying time is delayed when you are taking alcohol.
Okay. So clinical examination, he was a lean built but nourished male. There was no pallor, icterus, cyanosis clubbing, lymphadenopathy or edema. Head-to-toe examination, all systems were within normal limits. Respiratory system bilaterally equivalent, S1, S2 was heard, and the abdomen was soft, it was not distended or anything. And CNS wise only was affected because currently he is drowsy because of the benzodiazepine injection. So the diagnostic evaluation, we went with the clinical institute withdrawal assessment for alcohol.
Why you are given benzodiazepine in this patient? Is it really indicated?
The main indication was to calm him down. Benzodiazepine is one of the options we have for chemical restraints.
Okay, normal person.
In an aggressive patient, like there is an
In alcohol.
or a psychotic, all kinds of patients.
Okay, psychotic patients is okay. Alcohol.
Alcohol, the problem is if the patient is having concomitantly CLD, the effect of benzodiazepine can be prolonged.
Okay. In alcohol patient, benzodiazepine, whether it will be useful or slightly useless. If they are using illicit drugs like illicit alcohol, like alcohol which contains diazepam, long term if they are continuously using, your drug will become ineffective. So you should be very careful in alcoholic patients using diazepam. In a normal, somebody is taking a normal alcohol which is available through government supply, it may be okay, but other type of alcohol contains diazepam. So if they are continuously taking that, that's why many patients may not respond to diazepam in when they come with agitation in alcoholism. That will not respond because they are every day they are taking 5 mg or 10 mg along with this alcohol. That's why they don't respond. You should be very careful. Nothing will happen. It's not a problematic thing. It may not work.
So this patient actually, so we initially had a diagnosis of more of an alcohol withdrawal state. So we want to quantify it. So we went for a clinical institute withdrawal assessment for alcohol scoring system, which comprises of 10 elements. Basically, one is nausea, vomiting, one is headache, paroxysmal sweating, auditory disturbances, anxiety, visual disturbances, agitation, tactile disturbances, tremors, orientation and clouding of sensorium. In this, the first 9 will be having a score of 7 each, and the last one will be having a score of 4. The total maximum score is 67. That if the score is less than 10, it is a very mild withdrawal, and 10 to 15 is mild, just mild, and 16 to 20 is modest, and more than 20 is severe. In our patient, we came to a score of 28. So basically, in these patients, we have to repeatedly assess the score
A
after.
few parameters in the score, it will be hard to assess, no? How are you going to get your tactile sensations and all in a patient who is agitated?
Uh, that actually we cannot take into history. Like currently, it's not accessible.
Yeah. So that's the problem with the SIVA scores. Few things are subjective, like, and we may not be able to get a very reliable kind of feedback. Okay.
And also, this score has to be again and again reassessed after giving our benzodiazepines for any change in the values. And with this,
So above what score are you going to intervene? Above what score are you going to intervene?
the same scoring we have to repeat. Like,
No. Above what absolute score are you going to give benzodiazepines?
above this thing, 20.
It's 28.
He's having 28.
There again, based upon the score, you have moderate and severe. Okay, I believe the moderate will be somewhere anything about 10. Okay, about 10 means
Any score above 8, we have to repeated the this thing.
above 8, above 10 is most likely moderate, and then you there itself you have to start with your lorazepam. Again, depending upon the score, the frequency of the repeat testing also comes into. So
Initially we have to check every 15 minutes, and once the score comes below 10, we can repeat after 1 hour. And every 15 minutes, if the score is again high, we can give 2 mg lorazepam additional dose. So as to bring
the initial thing could be either oral or IV lorazepam based upon the patient's status. Okay. Fine.
So with this, actually, we come to a conclusion that the patient is actually having an withdrawal state of a severe withdrawal state, and which we are symptomatically managed with this thing. And also along with that, we started additional management. That is, we started with IV DNS with thiamine infusion. 500 milligrams started to DNS and started. And same time, actually, we gave our psychiatric OPGs actually a consultation for further evaluation under this thing also. And he was advised admission for detailed evaluation, because the one thing is actually he requires the criteria for admission. The criteria for admission is basically the patient who is presenting with or at a risk of delirium tremens. That is one thing. Second,
What's delirium tremens?
Basically, it is actually more like a severe stage of withdrawal in which patient is having delusion with.
So what are the stages?
Means.
What are the stages of alcohol withdrawal?
Initially,
1, 2, 3, 4.
Initially, the patient will only be having like craving or like just minimal.
Stage 1.
Then the patient will be like hallucinations.
Okay. 3 is withdrawal seizures.
Withdrawal seizures, and the
4 is
4th is
delirium
delirium tremens. So any chance of or risk of delirium tremens, any chance of risk of seizures, or also if the patient is having multiple comorbidities of the patient is frail, in this kind of patients we have to admit and observe. And also the patient, if they are willing for any medical assisted withdrawal or like de-addiction, which patients also we can actually admit. And also if the patient is coming with any other illness or symptoms, we have to admit. So this patient comes under the criteria for admission, so we are planning to admit the patient.
Okay. So here, one thing, any patient who is coming with withdrawal, one key question you have to ask is the precipitating factor, like in your encephalopathy. So some people here you told that the patient did not get alcohol, right? There could be other reasons also why. Could be some major pathological issue itself. Maybe an infection, maybe some of the intracranial issues, which is preventing him from getting alcohol. So always ask for a precipitating factor also. Okay. Next thing is that here you went ahead with benzodiazepine or lorazepam. Basically, you can give it as an IM dose before getting the intravenous access itself. So suppose you got a reasonable control with lorazepam, then it need not be lorazepam, need not be the only agent to consider. What are the other options you can consider at that stage once IV access is in?
Antipsychotics can be like haloperidol can be used, droliperidol, haloperidol can be used. Then
Something
can be used 2 to 5 mg.
Something which has been very much proven now in alcohol withdrawal.
Clodax.
Dexmedetomidine.
Okay, Dexmed will be a good choice. Okay. Other things, I mean, for acute control,
That will not have a problem in liver disease.
You can get him on a Dexmed infusion and control and titrate once you have the access. Acute control, again, ketamine or propofol can also be used for acute control. So that are the other options available. Okay. Yeah, carry on.
So if the patient is actually going to a stage whether we cannot control with benzodiazepines, we can actually go for intubation using propofol or in the drugs actually. That will be the final stage of control, like if you're not able to this thing.
Why you intubate this patient? What is the
And on this
recommendation?
patient, if the patient is not responding to our traditional management,
Responding means in what sense?
we are not to withhold them with benzodiazepines or
We are not able to control the agitation.
agitation, delusion, and all that.
Then we intubate.
Like
Putting a tube is always dangerous. Unnecessarily, we should not intubate. See, if the patient is having respiratory distress, aspiration, those things we should definitely intubate. Low GCS with the risk of aspiration. Only because somebody is agitated, we are intubating is not correct. Because whenever you are putting a tube, you are putting a chance of infection into the lungs. So you are breaking the barrier of natural protection. So you should be very careful. Avoid intubation if possible.
You have to always tell the bystanders that there is a chance of respiratory depression and intubation. That has to be explained to the relatives, and then you can optimize your sedation. Okay, most of the situations we will be able to manage without the tube itself. Okay, what is the key thing you are going to monitor? What is the level of sedation you are going to expect with drugs? Is there any score, or what's the sedation score which is used?
sedation.
Nice use.
We can use
Apache score.
Sedation score.
Richmond agitation score.
Agitation.
Sedation score.
Last score.
Basically, it has different values like +4 to -5, in which actually we can assess the patient. But the main thing is we will observe the patient, whether the patient is competitive, very agitated, restless, calm. This comes under positive characters. Negative will be drowsy, light sedation, moderate sedation, deep sedation, and unarousable. So in that, actually, our aim is to keep the patient in a score between 0 to -2. That will be,
-1 usually. Yeah.
that will be the ideal thing for treatment.
Okay.
This score we use mainly if the patient, we are not able to assess the patient, or like the patient is actually too drowsy to go for a clinical institute of withdrawal assessment score. So in our patient, actually, we didn't have to go through that extreme, so he was maintained with our basic management. And also in with these patients, actually, we have to assess for other complications which can arise actually while treating the patient, and which in this we have to give prophylaxis for to prevent any Wernicke-Korsakoff syndrome, in which the patient actually can go into a state of.
We cannot. How do you rule out Wernicke-Korsakoff syndrome?
The clinical features will be more like confusion and
Patient is already
confabulation.
It is not possible. How do you confirm if you want?
Mammillary
MRI.
bodies.
MRI should be done.
Mammillary
Mammillary body
bodies will be
changes should be done. So, but that is not practical in most of the hospitals in India. So, instead of rolling out that,
You can immediately start
you give
treatment.
time in. Okay, you should not wait for MRI to be done. That's a waste of money.
Also, people who are actually chronic alcoholics are always at risk of refeeding syndrome.
Okay, what is refeeding syndrome?
Basically, chronically, people who are actually having low nutrition, and their body will be depending on depleting the sources from the muscle tissue and all other tissues for sources of glucagon. Like they deplete the glucagon and they use it for glucose production. So in this patients, actually, we immediately start refeeding like a normal patient. Actually, it can cause further complications, like a shift of.
See, what you told is not refeeding syndrome.
Basically, when a patient is in a low and long-standing poor nutrition, there will be like energy metabolism of the patient changes. So when patient is suddenly started to be like refed, or even on a longer term, there will be a massive shift in the electrolytes, which will have potassium, magnesium.
You are not telling one
Phosphate.
That is very important. Phosphate is used for glucose metabolism. So that phosphate will shift drastically for this metabolism. And like you told, all other electrolytes also shifted. So suddenly patient had depletion in electrolytes, all these electrolytes, patient will go to
Arrhythmias.
they go to. That's why you might
failure.
have noticed many patients admitted to ward, suddenly doctors will start dextrose infusion. After sometimes patient arrests. That is because of refeeding syndrome. Continuously if you are giving dextrose in a malnourished patient, slowly these patients all electrolyte will come down and suddenly they will arrest. To avoid that, what you do? What is it? How do you avoid it?
We have to start feeding at a very low rate.
How much?
Like 25 ml per hour.
25 ml, 25% of the required nutrition. What will be the nutrition requirement in ICU?
20
Kilocalories.
Kilocalories. Sick patient require
2,500.
More than 8
More.
40 kilocalories per kg body weight is a requirement for a sick patient. Even pregnant lady also it is like that. Then 40 kilocalories per kg in a normal individual who is sick. In a suspected malnourished patient, it will be 10 kilocalories. Start from the first day. Every day you check the electrolytes, slowly increase. Over 1 or 2 weeks, you can make the normal diet. Okay.
Also, if the patient is actually a diagnosed case of CLD or in a suspicious case, actually we can, along with the treatment, we can start with anti-encephalopathy measures also.
Why anti-encephalopathy measures? In this patient, is there any liver disease?
In this patient, it's not documented. Like
Why we should give anti-encephalopathy measures?
like if this patient is not diagnosed, but in a diagnosed case,
Diagnosed case, we have to give. Okay.
we can start with lactose and rifampicin and everything we can give. So basically, this patient actually we manage because mainly because he doesn't have any other comorbidities. It's mainly an alcohol withdrawal.
So you have to rule out other differential diagnosis for altered behavior. Then you have to treat the agitation. Okay. What are the drugs you started?
This patient mainly we started tab lora. Once I settled, he started on tab lorazepam 2 milligram every 6th hour. We started.
Okay.
Then
What else? Patient may again ask for alcohol. How do you avoid all these things? So one is sedation, like you told, lorazepam.
Anti-craving method,
Acamprose 333. There is a dose. TID 3 times daily or 2 tablets 3 times daily. Then
What does it do?
Reduce
you can reduce the craving.
That's it.
Any role for clonidine in alcohol withdrawal?
Alpha agonist. It's an alpha
It's alpha
agonist.
So basically, it's usually used as a secondary agent along with benzodiazepines for controlling your dysautonomic features. Okay. Librium?
Librium is a brand name. Or diazepam.
Clodiazepam, that's also anti-crave. That's the ideal agent.
Previously it was used. Nowadays most of the doctors use
clodiazepam.
acamproside.
Okay, basically in alcohol patients actually the alcohol initially acts as an excitatory agent, then it acts as actually an inhibitory agent for the GABA, which is actually the major inhibitory neurotransmitter, and also it inhibits the glutamate, which is a major excitatory amino acid. So basically once we immediately take off the patient from alcohol, this GABA glutamate activity is actually increased. So the patient will be in a hyperexcitatory state, and this is actually the main reason for this agitation and all this irritable nature. So our priority is actually to control this agitation by other medications, and then also if the patient is stable enough to discharge, we have to always advise not to immediately stop the alcohol completely, because the patient can anytime go back into a similar state if we discharge the patient and ask him to completely abstain from this thing immediately after discharge. So we have to plan for a de-addiction, and then with that plan we have to discharge the patient. So in this patient actually we admitted for further management, and is currently undergoing treatment.
He may require psychiatric evaluation, counseling, de-addiction management, all these things. Okay. Thank you.
Okay.